So welcome everybody to the ASCP Virtual Pathology Grand Rounds. It looks like we are getting some attendees coming in and have a good quorum. So I'll go ahead and introduce our two speakers. We are exceptionally lucky today to have both Drs. Dayrup and Dr. Graves. Dr. Andrea Dayrup is a professor of pathology at Duke University. She received her undergraduate degree from Princeton University in the Department of Ecology and Evolutionary Biology before joining the University of Chicago for her PhD, MD, and residency. She trained in soft tissue pathology with Dr. Sharon Weiss at Emory University, and since 2015, Dr. Dayrup's career has focused on medical education. At that time, she joined the faculty of the Duke Pathology Department as course director of the first-year medical school pathology course. She serves on the Undergraduate Medical Education Council for the Association of Pathology Chairs, participated in the 2020 to 2021 Duke Teaching for Equity Fellows Program, and was a member of the Duke School of Medicine Health Professions Anti-Racism Task Force. She is one of the co-editors of the new Robbins Pathology textbook, Essential Pathology, and of the upcoming 11th edition of Robbins and Kumar Basic Pathology. She's actively committed to anti-racism efforts and to improving discussion of health disparities in medical education. Next, I'll introduce Dr. Graves. Dr. Joseph Graves is a professor of biological sciences at North Carolina Agricultural and Technical State University. He received his PhD in environmental, evolutionary, and systematic biology from Wayne State University. His research in the evolutionary genomics of adaptation shapes our understanding of biological aging and bacterial responses to nanomaterials. He has multiple books on the biology of race, including The Emperor's New Clothes, Biological Theories of Race at the Millennium, The Race Myth, Why We Pretend Race Exists in America, and Race and Racism, Answers to Frequently Asked Questions, and that book is with Alan Goodman. He leads programs addressing underrepresentation of minorities in science. He aids underserved youth in Greensboro via the YMCA Chess program. He has also served on the Racial Reconciliation and Justice Commission and COVID Vaccination Task Force of the Episcopal Diocese of North Carolina. And he serves as the science advisor to the Chicago and New Brunswick Theological Seminaries through the AAAS Dialogues of Science, Ethics, and Religion program. Welcome, Dr. Dayrup and Dr. Graves.
All right, thank you very much. I will go ahead and let's get started. We have a very exciting program with a lot to cover. All right, so the title of our talk, and something that perhaps brought in a lot of you, is Nearly Everything You Learned About Race in Medical School is Wrong. And I hope that over the next 45 minutes or so, we will convince you that this is correct. We are absolutely delighted to be speaking to such a broad audience. We have been giving this talk pretty much continuously over the last year or so. These are the departments and institutions where we have presented versions of this work going through September 2022. So this is about an 18-month period. And one thing to keep in mind as you look at this is that the talks that we've given that are listed in maroon are outside of pathology, because what we'll be talking about is something that is so important that it really affects all of medicine. So let's go ahead and get started and share that with you. So I'll begin with a disclosure, which was, as mentioned, I'm a co-editor author of 2 of the Robbins Pathology textbooks, and Dr. Graves is a paid consultant on Robbins and Kumar Basic Pathology. Over the next 45 minutes or so, we're going to discuss the impact of systemic racism in health professions curricula, compare and contrast biological and socially defined race, evaluate disparities in the pathophysiology of disease, and describe an approach to addressing health disparities in healthcare education. So the first question, when we're thinking about when we say that nearly everything you learned about race in medical school is wrong, is to ask, how does race show up in the curriculum? So as you all know, I'm a pathologist, and this is the book that I've been teaching from. This is the 10th edition of Robbins Basic Pathology, which we use at Duke. And as I first began looking into this, and those of you who are attending the resident roundtable will hear how I got involved in this process. In order to see how race showed up in the curriculum, I did a search through the electronic book using terms like Asian, African, Caucasian. And I found more than 35 different diseases for which some sort of disparity was associated with socially defined race. And I've listed a number of them here. Now let's take a look at how these disparities actually show up in the text. So here are some quotations from the 10th edition referring to African Americans and cardiac amyloidosis, carrier frequency of cystic fibrosis in Caucasians, cholesterol gallstones in Native Americans, and factor V Leiden mutation in whites. So before we move on, we need to stop for a moment and recognize, right, first of all, that this terminology is outdated. And one would think that it would be very easy to just simply address the outdated terminology, but that has actually been more challenging than you might imagine. But that is something which is a separate issue. Let's think for a moment that when these sentences were written, and the first Robbins textbooks came out in the 60s and 70s, when they were first written and as they've developed over the decades, they were written with the best of intentions. They were written with the belief that these epidemiologic data would help future physicians to design an appropriate, broad yet focused differential diagnosis, order the laboratory tests that would confirm or deny that diagnosis, and then ultimately to design the optimal therapy for their patients. So these sentences were written with the best of intentions. But as we all know, it's not enough to simply say, well, I had good intentions, right? Particularly when we look at anti-racism work. We have to look at the impact. We have to ask, are we causing harm? So are we causing harm? And I would say yes. And there are three areas I'd like to look at. The first is something I call buzzword bingo, right? So we take very motivated, very bright medical students who are very good at multiple choice questions, and we teach them simple word associations: white, cystic fibrosis, black, sickle cell disease. And we reinforce this through multiple choice questions, through vignettes, through board prep exams, and through the board exams themselves. So let's take a look at one of these board prep materials. This comes from a 2015 website, Rules for Step 1, crashingresident.com, giving advice to medical students preparing to take the first of their step exams and how they could do well on this multiple choice exam. And one of the pieces of advice was be as racist as possible. Now, as you look over this as I'm speaking, some of you will be thinking, oh my gosh, this is just horrible. And others of you will be nodding your head and saying, yes, you know, this is what I learned when I was preparing for my step exams, that these associations are going to help me do well on my step exams. Now, you may be saying that, you know, this is just something from 2015 and this is just a one-off. Let's look at something a little bit more data. So this comes from 2017, a paper by Lundy Braun, who wrote Breathing Race into the Machine, a book I highly recommend looking at race in pulmonary function tests. Now, we can't look at the actual USMLE questions. Obviously, those are very secure. So they did what they would consider to be the next best thing, which is to use a very widely used test prep resource, UWorld. And what they did was they looked through the entire question bank of step 1 for the USMLE in UWorld. And at that time, it was about 2,100 questions. And as they looked through it, they looked to see whether race or ethnicity were mentioned. And if so, they noted which race or ethnicity and whether the term was descriptive. So it was just a patient characteristic, had nothing to do with arriving at the correct answer, or if that race or ethnicity was central and you had to make that association in order to get the correct answer. And you can see here their table looking at the mentions. Now let's begin, first of all, by looking at the category white Caucasian. You'll see here about 93% of the time, if the patient in the vignette was white or Caucasian, it was purely descriptive. They just happened to be that particular socially defined race and something happened to them. And about 7% of the time it was central, so cystic fibrosis, coronary artery disease, something like that. Now, as we look at this, let's notice as well that this particular socially defined race was mentioned 407 out of the total 474 times that race or ethnicity was mentioned. So that comes to about 86% of the mentions. Now, if we think about this again, we know that based on the 2020 census, we're talking about a socially defined race that accounts for about 62% of the American population. So we could say, if we were just making just a general observation, that we have an overall focus on a particular group. But even more concerning, I think, than the overrepresentation of the white/Caucasian group is, let's take a look at Native Americans. So if a Native American shows up in your vignette, it is because that person is that socially defined race. They weren't in a car accident. They didn't brush up against poison ivy. They are there because they have gallstones or lactase deficiency. So that brings in this association that we make between race and disease. Now, as you look at these, you may be thinking, as you reflect back on your own education, well, yes, but those are the preclinical years. And as students go onto the wards, as they go through residency and become attendings, they recognize the breadth and the span of health and disease, and they'll recognize these associations aren't correct. And I will tell you that there are things I learned 20 years ago at the University of Chicago that I did not learn were false until I started doing this work. And I will tell you that of the more than 20 presentations that Dr. Graves and I have given across the country, we have found that many of these associations persist, and there's a very strong belief in biological race. So let's move on to our next question. Is there a way that we could be causing patient harm? And again, I think the answer is yes. So say a young Navajo woman presents at an acute care clinic, she's got right upper quadrant pain, and the attending thinks, Native Americans, got to be gallstones, and doesn't think of ectopic pregnancy or acute appendicitis, either of which could cause the patient's death. Now, again, you may be saying, oh, this doesn't happen. We've got checks and balances. We have algorithms. This would certainly be caught. Well, let me bring your attention to an anecdote from the literature in which the author recounts the story of a childhood friend who wasn't diagnosed with cystic fibrosis until she was 8 years old. Now, most children with cystic fibrosis are diagnosed within the first 1 to 2 months of life, if not prenatally. And here we see someone who wasn't diagnosed until she was 8, despite presenting multiple times with suspicious symptoms. And in fact, she was only diagnosed when the clinician literally was prevented from seeing her skin and was looking at a chest x-ray and said, hey, who's the kid with cystic fibrosis? Being unaware of the patient's race was how the radiologist was able to make the diagnosis. There have been other reports in JAMA saying that cystic fibrosis is not a white person's disease. So we have this, which is continuing through healthcare. And then finally, since we're looking, right, I think we have to ask, is there a way we are causing societal harm? Is there a way that we are subtly or not so subtly lifting one population up and putting another one down? Are we saying bad genes, risky behavior, non-compliant? Are we causing some sort of social hierarchy? So let's take a look at once more at the diseases that I found in the 10th edition of Robbins. And to make this easier for you to visualize, I'm going to redline for you the diseases that are described as being more common in African Americans. And by contrast, here you can see for European Americans. So yes, I think we are setting up a hierarchy. Now, you may say, you know, and this really depends on your positionality, right? Because if you look at this, you may say, well, you know, this isn't such a big deal, but let's look at what our learners are experiencing. So this comes from the book Black Man in a White Coat, a doctor's reflections on race and medicine. Dr. Tweedy actually went to medical school at Duke and is now on the faculty as one of my colleagues. And this is what he wrote in that book, right? Something that we just demonstrated through that previous visual. It seemed that no matter the body part or organ system affected, the lecturers would sound a familiar refrain. It's more common in Blacks than in whites. Each time the demographics of a new disease came up in a lecture, my stomach twisted. I knew where this was heading. Seated in a sea of mostly white and Asian faces, I wondered how this information affected their views of Black people, whether they already had biases against us, and whether any of this impacted the way they saw me. So this is what we're talking about with race. Now I'm going to turn this over to Dr. Graves so we can actually say, what are we talking about when we talk about race?
Thank you, Dr. Dara. So the elephant in the collective living room is what exactly is race? Now, in modern biology, races are defined by two criteria. The first being the amount of genetic variation within and between subgroups within that species, and whether any group within that species can be considered a phylogenetically unique or evolutionary unique lineage. Now, it's long been known that in our species, anatomically modern humans, that there is more variability within so-called races than between them. Now, that is not to say that we do not have geographically based genetic and physical differences, but all humans share 99.9% of their genome in common. And to give you an idea of what genomic variability within our species looks like, if we were to take two African individuals chosen at random, and we were to take an African and a European individual chosen at random, the African and the European individual are more likely to share any specific genomic variant than the two Africans are. And the reason for that is because the vast majority of the genetic variability within our species resides on the continent of Africa, and the rest of the world is really a subset of African genetic variation. Next slide. So biological races do not exist in modern humans. On the other hand, socially constructed or socially defined race arbitrarily utilizes aspects of morphology, geography, culture, language, and religion, or any other attribute one desires, but it only does so in the service of a social dominance hierarchy. So in my new book with my colleague Alan Goodman, entitled Racism, Not Race, we make the point that it was racism that created the socially defined racial categories that dominate social life in the Western world, not the underlying biological genetic variation that exists within our species. Now, this is beginning to get greater recognition in scholarly circles, including, for example, in the Introduction to Epidemiology, 7th edition by Merrill, where they say race is a socially constructed variable based on the idea that some human populations are distinct from others according to external physical characteristics or places of origin. But Merrill goes on to say that racial or ethnic variations in health-related states or events are explained primarily by exposure or vulnerability to behavioral, psychosocial, material, or environmental risk factors and resources. Note that Merrill does not say that these differences in health-related states are due to differences in the frequency of genomic variants between purported racial groups. Next slide. Now, this confusion is even more illustrated when we look at the categories used by the US Census Bureau. For example, white, a person having origins in any of the original peoples of Europe, the Middle East, or North Africa. But this begs the question, how much origin in those regions do you have to be considered white? Black or African American, person having origins in any of the Black racial groups of Africa. And once again, how much? Okay, considering that there's more genetic variability on the continent of Africa than all the rest of the world combined. American Indian or Alaska Native, person having origins in any of the original peoples of North and South America, including Central America, and who maintains tribal affiliation or community attachment. But of course, that means that a person of that ancestry who no longer affiliates with their tribe is suddenly no longer an American Indian. Asian, person having origins in any of the original peoples of the Far East, Southeast Asia, the Indian subcontinent, including Cambodia, China, India, Japan, I could go on. And my response here is, really? Because we're talking about a huge geographical expanse with populations that do have genetic variation between them and cultural variation, social variation. So the question becomes exactly how useful is this category? Native Hawaiian or other Pacific Islander, a person having origins in any of the original peoples of Hawaii, Guam, Samoa, or other Pacific Islands, with the same caveats. Exactly how much do you have to have before you're no longer considered Native Hawaiian or other Pacific Islander?
All right, so thank you very much for that, Dr. Graves. Now, as you could see from that US Census description, what we're really seeing to be talking about is geography. So let's put geography in the context of a disease, or specifically a group of diseases, the hemoglobinopathies. So you can see here, this is a map showing the distribution of a variety of hemoglobinopathies. And as physicians, you're all aware that these arose and became prevalent based on protection against malaria. So where you're going to see these diseases is going to be where there is malaria. So we talk frequently about sickle cell disease as being something that we associate with African Americans. But looking at this, you can see, well, it's also actually in Southern Europe, in parts of the Middle East, and in parts of India. We can see as well that as we look at these distributions, that we're not talking about a particular political boundary. So it's not restricted to a country. It's not restricted even to a continent, right? What really determines your risk of these particular diseases is whether or not there are mosquitoes and whether they carried malaria. And so if we were to look here at this area in Africa, you see, look, there's no hemoglobinopathies here. And this really brings us home. Why are there no hemoglobinopathies here? Because this is where the Sahara Desert is. There's no water, there's no mosquitoes, no malaria, no hemoglobinopathies. Now, I also want to make one point about this map, which is that it looks very neat and tidy, but actually we see these diseases now globally because as people move and emigrate and immigrate, they're no longer staying in the area where these historical associations, these evolutionary associations arose. Now, let's take a look again, just purely at Africa. And we can see here, as we look at this map, that sub-Saharan Africa has a significant amount of hemoglobin S. We see some hemoglobin C here in Western Africa. And if we were to align this with a map showing the origin of enslaved peoples from the history of our country, you would see that even if you didn't know very much about modern America, you would expect us to have a small amount, perhaps, of hemoglobin C and more hemoglobin S. And you would be right. These are data that come from a study from Howard University's sickle cell screening clinic. And you can see that while most people are wild type for hemoglobin A, we see hemoglobin S as well as hemoglobin C. But a point that's important to mention, so I talked about the evolutionary pressure from the past, it actually continues because, as you're all aware, malaria continues to be a problem in a large part of the world. So if we look at sickle cell trait in the United States, it's about 8 to 10%, whereas in parts of Africa, it can range from 15 to 28% because there is ongoing pressure from malaria. So this becomes important because as we consider the fact that we have a significant proportion of the US Black population is foreign born. So we have continual admixture going on. And when we add to that the fact that the mean amount of European ancestry is about 16% for African Americans, defining African Americans as those descended from enslaved persons, we see that population admixture is going to color our ability to look at people and think we can assume we know something about their geographic ancestry. And this is so important, I'm going to turn the issue of admixture over again to Dr. Graves.
Thank you, Dr. Dara. So when we look at socially defined groups like African Americans, it's important to recognize that African Americans have both African and European ancestry. Now, this occurred primarily during chattel slavery, and this admixture differs depending upon the region of the country in which African Americans are living. So in the Southeast, you tend to have mean European ancestry in African Americans of around 16%, which is the national average. But individual states differ dramatically, such as in West Virginia, where the mean European ancestry in African Americans is in excess of 30%, or in states like Washington State, where you also have in excess of 25 to 30% European ancestry in persons socially defined as African American. Next slide. Now, this is even more complex when we consider people socially defined as Latino, as their European ancestry can vary from 65 to 85%. This population is a triad mixture of European, African, and Amerindian ancestry. And again, this can differ dramatically depending upon the origin of the Latino population in question. Next slide. So for example, on the island of Puerto Rico, individuals are on average 72% European ancestry, 16% Amerindian ancestry, and about 12% African ancestry. Now compare that in contrast to Mexicans, who represent the largest Latino population in the United States, Mexican Americans, who are on average 51% Amerindian, 46% European, and only about 3% African ancestry. Now, if we go to a nation like Peru, individuals there are 80% Amerindian ancestry with only about 18% European ancestry. And in a nation like Colombia, which has a triad mixture similar to what we see in Puerto Rico, 64% European, 29% Amerindian, 7% African ancestry. But within the country, depending upon the location, you can get dramatically different ancestry profiles. Next slide. So, for example, in the city of Medellin, we see a triad mixture which is similar to that of the national average. But in the neighboring state of Choco, which was a site of colonial agriculture, the individuals there have on excess of 80% African ancestry and only a small amount of European ancestry. And again, probably on the order of 15 to 20% Amerindian ancestry. And this is, again, two regions that are literally right next to each other in the nation of Colombia. And all of these people consider themselves Colombians. So next slide.
All right. So I hope by this point, everyone who's watching this agrees race is not a biologically useful construct. Okay, so why are there racial disparities in health and disease? So there are a couple of different ways we can think about disparities. And one way that we describe them as intrinsic or genetic causes of disparities. So these will be things like a founder effect or a population bottleneck. So for example, the higher incidence of severe combined immunodeficiency in the Navajo and Jicarilla Apache, Tay-Sachs in the Ashkenazi Jewish population. Both of these due to the decimation that occurred due to the genocide of the American Indians in our history and due to the Holocaust. But what is being affected here are not races, but populations. Now, another cause of intrinsic disparities is endogamy. And this means marriage within, but more specifically, of course, breeding within one's group. And this can be based on religion or caste or geography. But again, it's populations, not races. And then as we looked at with the hemoglobinopathies, there are selective advantages to historical pathogens. But again, this is due to geography. So while we spend a lot of time and a lot of money looking at subtle differences in alleles and genome-wide association screening, trying to tease out these differences in these populations, if we're thinking about the causes of disparities, the real impact comes from the extrinsic causes. And these are things like poverty and access to care and living conditions, many of which obviously are linked. And all of these are colored by individual, institutional, and systemic racism. Now, these three terms, the different types of racism, are talked about in the lay public, in the popular media. But I'm going to take a moment to discuss that and bring it into medicine. So this comes from the website dismantlingracism.org, and which I highly recommend. Just throughout this talk, we use the terms that are used in the various publications. So here we look at personal racism, which are the individual acts. And I will say that in previous talks that I've given, Dr. Graves has been present, obviously, for all of them. I've said that, the personal expression of racism, which I think of as, men in white robes burning crosses, is not as prevalent as institutional systemic racism. But I think the events that we saw in the recent Brooklyn shootings show us that institutional, systemic, and personal racism all feed each other. So we can't simply say, well, let's just dismiss that aspect of it. It's not as important. It's all linked. So institutional racism are the policies and practices of institutions like universities and hospitals that include and serve and financially resource white individuals at the expense of individuals who are not of that socially defined race. And a medical example of this is that when phenylketonuria testing was first begun in that first screening clinic, they said, well, we only need to do white kids because Black kids don't get this disease, which of course we all know is false. And then cultural systemic racism are the beliefs, values, and norms of a society that, again, uplift and validate and protect individuals of European descent at the expense of communities of color. An example of this is going to be access to healthcare, because our society does not believe in universal healthcare. And there are, of course, even more issues that have come up recently through some of the recent developments in our country. So let's take a look, again, tying this back to medicine, of how these extrinsic causes can have an impact on health. So this is a quotation from Up to Date based on the 2 studies listed below. And in it, the authors looked at populations who are undergoing hysterectomy. Now, as you're aware, there are 2 general categories of hysterectomy. There is an open hysterectomy with a somewhat sizable transabdominal incision. And this can have a significant morbidity. It takes a long time to heal from this. One has to take days off of work. One cannot lift heavy objects. And in contrast, there are minimally invasive techniques such as a transvaginal hysterectomy or a laparoscopic hysterectomy. And what these 2 studies showed is that for women who were eligible for either type of hysterectomy, if they were Black, Hispanic, or publicly insured, they were less likely to receive a minimally invasive technique compared to white women. And the factors that contribute to this, I would say, would be systemic racism because of the link to public insurance, institutional racism because the hospitals that served these populations had fewer surgeons who did minimally invasive techniques, and then poverty, education, access to care, health insurance all contributed as well. And then this is a sentence from the 10th edition of Robbins talking about the pathologic effects of high blood pressure in African Americans. And we would say that all of these have an impact on this. There is no slavery gene, right? This is a combined effect of all of these different factors. So what do we do next? Okay, so we've looked at this. We're aware of this. Race, there is no such thing as biological race. How do we address this in our curricula and as physicians moving forward? And this is what we recommend. So you have to begin with a thoughtful, mindful analysis of the material driven by data. And so for me, what this was like is whenever I see socially defined race assigned with an outcome, I have to ask why. And I do a deep dive into that. And I'll show you some of that in a moment. We need to have inclusivity and we need to provide context. So for those 35 plus diseases that I mentioned that I found disparities in Robbins, I actually did a deep dive into literature and generated about an 85-page document with figures and references. You can email me and I'll send that to you. It's freely available. But let's see some of what I've discovered in that. So the first question we have to ask whenever we see socially defined race coming into it is this even true, right? So let's begin with a sentence from the 10th edition of Robbins referring to keloid formation in individuals of African descent. So I wrote the editor of that chapter and I said, I would recommend removing this. And he said, this is what it says in Up to Date. Now, as I mentioned, I've been working on this disparities document for my students. So I had read Up to Date. And in fact, I'd also read reference 5, which was by Robles and Berg. And we'll get to the 5 to 16% in a moment. But one of the things that caught my eye in this article was this particular statistic saying the risk of developing keloids is about 15 times higher in dark-skinned individuals compared with whites. Now, 15 times is a big number, right? So that sounds like it's got to be statistically significant. And the other reason it caught my eye was because I saw this in multiple publications. So here are 4 others that use that exact same statistic. Now, I believe that the index paper was this one by Brissett. That was the earliest incidence of this statistic. Let's see what Brissett says. They say, in a review of 175 cases of keloids from various races, the authors found that keloids were 15 times more likely to occur in darker-skinned individuals. Well, let's take a look at that paper by Al-Hadi and Savannah Farah. Why don't we? So that's from 1969. It was done in Malaysia. So that's why they were looking at Chinese, Indians, and Malays. And what they say in their paper is that the relatively fair-skinned Chinese appear to be slightly more prone to keloids than the dark-skinned Indians and Malays. So the arrow's pointing in the wrong direction and the number is wrong. So I did the math and I come to about 2 to 3-fold increase. Okay, but this has gone on through the literature, right? As you can see, the multiple papers that use the statistic. So let's back up a moment. Let's look at this 5 to 16%. So where does this come from? I have a video on this. I'll send you towards that in a moment. But basically, I went through the literature, pulling on this thread further and further and further back. Everyone's referring to this publication and that publication, and they're all review articles. Let's find the actual data. The actual data did not show up until 1931 on May 17th. Now, those of you who are looking at this is written in French, and so that might be why you're not able to interpret it, but I will tell you what it is. So this is from a dermatologic meeting in Strasbourg. And in it, Monsieur Lespin gave a talk on tattoos and keloids in the Negros of the Congo. So he gave his talk, and afterwards someone leaps up to the microphone, as so often happens at meetings, instead of asking a question, says, oh, let me tell you my experience and present my own data. This was Monsieur Staub, who was from the Belgian Congo, from Leopoldville. And he said, oh, by the way, when I was there in the Congo, I looked at 1,205 Black adult workers who were working in the mines. So let's just pause for a moment and think about the colonial exploitation that this is talking about. This person who says, I'm going to look at 1,205 adult Black workers and examine them for their keloids. And what he found was, after looking at all of them, he found that 16% of them had keloids. So that number from May 17th in 1931 goes all the way up to 2021 with 16% in up to date. So that's bad enough that we have, 90 years from this one person. It's not even peer reviewed. It was just someone leaping up at the end of a presentation. But what I think is even more egregious is that that very same meeting on May 17th in 1931, in this same journal article, we have an actual paper put forth by Monsieur le Professor Nagli from Bern, Switzerland. And what Professor Nagli did was he was looking at keloids in Swiss adults and children. And I've just put the relevant part for adults. What he did is he wandered around and looked at everybody and he looked to see if they had keloids. And he found that 13.3% of them did. So here we have neighboring publications in the same journal. And anyone looking at this in 1931 would say, 13.3%, 16%, not that different. Aside from the fact that even if you were to say this is really important, we can say this is what it is in this population in the Congo and in this population in Switzerland. We can't say all Europeans or all Africans have these numbers, right? But the number that makes it through isn't the fact that we're really not all that different. What makes it through is 16% of Africans have keloids. So I presented all of this to the editor, and this is what we ended up with in the next edition of Robbins. Keloid formation seems to be an individual predisposition. Now, I will say as an aside, my belief as an author is that if you are going to include socially defined race as something in your publication, which I typically don't recommend, it should be the responsibility of the author and editor to show why this is important. It should not be the responsibility of someone else to say, hey, why are you doing this, right? If you're going to put this in the publication you are doing, you need to backstop it. You need to show that it is relevant, okay? So this is what it says. It's an individual predisposition, and it is, right? But the question we come to again is, why are we linking this to race, right? Because if we're talking about keloids, you don't need to look at the color of somebody's skin to see if they might get a keloid. You can look at their actual skin. Because by the time someone is adult, maybe looking at some elective surgery, we've all had a scrape or a cut, a piercing, maybe multiple piercings. And if you're going to get a keloid, you'll probably have a keloid. Now, what about for children? Well, we know that there can be a familial predisposition. So you should ask, about the child's brothers and sisters, cousins, aunts, uncles, grandparents, parents. And that's going to give you a better idea of that individual's genetic heritage than looking at the color of their skin. And this is important because as we do this, right, if we take a careful physical examination and we do a careful clinical history, that's going to tell you so much that you need to know, and will cover not only genetic issues, but cultural and social ones. If there is perhaps a food or a drink or a folk medicine that a family uses, and you have people who have the same issue coming up, that's going to help you to identify it. So I put all this together into a video, which you can find on my website, pathologycentral.org. And we mentioned this, I actually emailed the editors of that section of Up to Date beginning many months ago, and said, there's a problem. And they said they'd look at it, and they fixed part of it. They didn't fix all of it. So in our New England Journal of Medicine article, we said, by the way, it still hasn't been fixed. And they fixed it. So this is what it said before we got started. We have here, they've been reported in 5 to 16% of individuals of Hispanic and African ancestry. What it currently says is it's gone, right? And it has actual data relating to a specific population. So science wins. But I will tell you, for those of you doing this work, as you do this, what will happen next is someone's going to say, but what about? And they will cite for you 1 or 2 papers saying, look, here we found something that shows something that's relevant. So after our New England Journal of Medicine article came out, someone wrote a letter to argue with that, which was sent to us. These were the 2 papers cited in that letter. That letter was not published because it had fatal flaws. But of course, we looked at these 2 papers. So these are what these 2 papers showed, right? And so the authors of the letter said, see, look, keloids are more common in African Americans. And if you look at these studies, so we have this first one with about 430 patients showing a keloid incidence of 7.1% in African Americans, with an odds ratio of African Americans compared to whites of 16.5. We have a second one with many more patients, which shows a very different keloid incidence, right? And a very different odds ratio. So this tells you already that if you're thinking that you're having some sort of insight that because the definitions are wrong, because these populations are different, you can't simply make these sweeping comments about socially defined race. And I think that's what Dr. Graves and I were showing earlier, is that these socially defined races are very heterogeneous. So the final thing I want to talk about is if it's true, is it clinically relevant? And I say this because I think that there are some things that are clinically relevant. My question at this point, is it relevant for us to teach to medical students in the preclinical years? So this is something that comes from Up to Date, where we're talking about lupus. And in Up to Date, it says that about 164 out of 100,000 European American women compared to 406 out of 100,000 African American women have lupus. And the study, which is cited here, is actually looking at 2 different populations, one in Pennsylvania, one in California. Again, you can see we have significant variability, 1 in 3.4 versus 1 in 2.4. But I did the math here with a brilliant epidemiologist, because I wanted to say the reason people say, well, we need to emphasize these racial differences is because it helps us make a good differential diagnosis, and it'll move things up and down our differential diagnosis. So someone else had said to me, it helps because for our tests, for our positive predictive value. So here is looking at the positive predictive value. If we look at an incidence of 1 in 100 versus 4 in 100, and you can see for a single test, if we are talking about a test with 95% sensitivity and 95% specificity for that one test, the difference between this is 17% and 44%. So if an African American is positive for that, it's 44% chance that it's actually correct. But if we take it to 1 to 1,000 versus 4 to 1,000, which is what essentially this ratio is, it drops to about 2% and 7%. So why are we emphasizing this? What we should be basing this on is the constellation of symptoms based on the clinical history, based on the physical exam, not just looking at the race. But despite this, despite the evidence that race is not significant in this, this is what it will say in the next edition of Robbins Basic Pathology. So how do we fix this, right? So if you're feeling inflamed and you're like, I want to fix this, this is one of the things that is critical. You have to build a team because I have my positionality, and the only way that I can see what other people see is to ask them and to bring them on as allies and respected colleagues, not just someone I call up, but let's pay people to be part of our team. And I will say that my own personal journey is that at the beginning, and I recommend this to you who are just starting out, start off with people who are gentle and who you can lean into and learn. And then you have to, as you become more comfortable, go further. Go to the people who really challenge you, who will say to you, you're not seeing clearly, who will really call you on it. And it becomes more and more challenging, but that's the only way we can affect change. We need to bring in the students and the trainees, okay? Because from my positionality, you know, I'm 54 years old. I learned very race-based medicine at the University of Chicago. I am white presenting. I see things in a certain way. The younger generations, I think, are seeing things differently. And so, for example, when we were working on Robbins basic pathology, I put up a Google Doc for our medical students. I said, if there's anything problematic, here's you know, an anonymous way you can let me know so that we can address this. And finally, we need to be sure that we are inclusive in what we do. So inclusive images. So at Duke, we teach using a website. We have cases with clinical images and virtual microscopy. And when I first began with the influence of one of my team members, I removed race and ethnicity from all of our vignettes. But we still have clinical images. This is a basal cell carcinoma. If you read Robbins, you know it's more common in individuals with lightly pigmented skin, and there you have it. What we did 2 years ago was not just to show an image, let's show it in multiple skin types. And this is really relevant because if you look at this in an individual with a darker skin type, this could mimic a melanoma. I see variation in color. I see an irregular border. I see dark pigmentation. I see ulceration. I could mistake this for melanoma. If we don't show this to students, how can they possibly learn? We've actually done that in Robbins as well. So there are multiple images and multiple skin types throughout the book. And then we need to have appropriate terminology and provide context. So this is a sentence I showed you earlier. About 2 to 15% of whites have the factor V Leiden mutation. So in our edits of this, since we don't want to use the term whites, because then you use browns, yellows, blacks, and reds, and nobody wants to do that. And since we know this is actually an intrinsic cause of disparity, it's associated with ancestry, we want to emphasize that European ancestry, but we don't want European ancestry to be a code word. You know, when Dayrup says that, she means white. So we want our students to recognize that we can see this in other American groups, largely due to population admixture. And this is critical. There was a very touching article in NPR many years ago about an African-American woman who had factor V Leiden mutation and they finally figured out it was in her family. And you know, you don't think of this because if you have the original statement, it's seen in whites, completely discounting, you can see it in other populations, it doesn't show up in a differential diagnosis. So this whole idea of, you know, we have to make these race-based associations so it will help us make the correct differential diagnosis, it actually hinders us from making an appropriate differential diagnosis. And as you know, it's particularly important for factor V Leiden because heterozygotes can manifest with thrombophilia. So let's talk about this appropriate terminology. So Dr. Graves and I made this distinction in an article that we have in Academic Medicine with Dr. Lainey Ross, that Black does not equal Black with a capital B, does not equal African American, does not equal African descent. Similarly, all of these other different terms are not interchangeable, and the way that we use words is very important. And I'd like to turn that over to Dr. Graves so he can give his input on his understanding of this and why it's important.
Yeah, it goes back to what I was discussing earlier about, you know, biological variation and the disconnect between underlying biological variation and socially defined racial groups. So if you say, for example, that someone is Black, that's a social definition that encompasses people not just from the recent African diaspora, but that often could also include people who are Australian Aboriginal people. If you say that someone is African American, it depends upon, you know, your definition of African American. Does it include recent African immigrants? Does it include people who came from the Caribbean to the United States? Does it include only those who are the descendants of people who were enslaved in North America. So you have to be really clear on who you're talking about and under what context are you talking about those people. And this desire to come up with simple terms that can be used across the board is scientifically incorrect and misleading.
Excellent. Thank you so much, Dr. Graves. So I'd like to finish by asking, right? Have we shown this? Is it true that nearly everything you learn in medical school about race is wrong, right? Because that's a bold statement. And I think the answer is yes. And the reason is that biological race does not exist. And if you think back to what you learned in medical school, there was this very strong assumption, presumption, or even explicitly taught that biological race exists. And even though, right, people like myself and Dr. Graves and others are saying, you know, biological race does not exist, and we say this very loudly, right, there are still very senior people who still, even when you say that biological race does not exist, there's that little, yeah, but there are differences based on race, or how do you account for this race? And we acknowledge completely that there are geographically based differences, there are population differences, but race specifically, right? Biological race does not exist. Now, we have to recognize that socially defined race has a tremendous impact on health disparities. And we can comment more on this about why it is important to track how, socially defined race and vaccination, socially defined race and access to care, to health insurance. Because if we don't make sure that, then if we don't acknowledge that, then we cannot possibly have equity. Here is the long list of references that we've used in this. I can make those available to you. And you can you can email either of us. We are both on Twitter. I have a website called pathologycentral.org that has videos with undergraduate medical education pathology videos, as well as race and medicine, which I hope to really get back more to once we're finished with this edition of Robbins. For those of you who are interested in diversity in pathology, I highly recommend following Diversify and Path. And then there are some fantastic podcasts by Dr. Michael Williams. And then finally, this cartoon comes from Dr. Obobi, who I know because she is at the University of Chicago, my alma mater. She's a fellow in cardiology, and she has a website and does cartoons that have very trenchant comments on race and medicine. She has a book that's just come out called On Rotation, which is a novel, which I think is a great way to get a different view of a different positionality. It's told from the position of a Ghanaian American who is a third-year medical student. So I think it's really quite valuable. So with that, we will stop sharing and take any questions.
All right. Thank you both, Dr. Darup and Dr. Graves. I have learned so much today, and I really appreciate the kind of objective and data-based dismantling, as you said, of some of these constructs that we've just been taught and assumed were based, on more sound data than actually exists. So there is an interesting question in the chat that I think is especially important in pathology, because I had really latched on to your example about the radiologist who diagnosed cystic fibrosis because they weren't kind of biased in advance, knowing anything more about the patient. They just saw their x-ray. So pathology in many ways has the advantage of not necessarily seeing a patient, not having some sort of preconceived notions about what this may be. But this individual asks, what if we need to flip the question? Are there instances where having specific information about a patient can positively impact how you prioritize your clinical approach or differential diagnosis?
Do you want to take that one first, Andrea?
Why don't you go ahead and take this one?
So the answer to that is absolutely yes. Having information about the patient can definitely help you with your differential diagnosis. But the question is, which information are you talking about? So if you mean someone's socially defined race, my answer would be probably not. If it were the prevalence of a specific condition in that patient's family, such as mother and father both had type 2 diabetes, that would be a useful thing to know. Or, mother and father both had G6PD deficiency, that would be a useful thing to know. But you're not going to know that based upon someone's, where they fall in the social definitions of race. And that's the confusion that people are making. One, that these socially defined groups are real biological entities. And even if they were, okay, that would still not tell you whether any given individual within that biological entity has a specific risk factor for a given disease. You would find that from their family pedigree. So if that's the case, why would you be concerned with the social definition, since the family pedigree is really what you want to know?
So I want to embark on this. This is something I'm currently really wrestling with. So one of my close colleagues with whom I've been working on this for a while is Dr. Lainey Ross at the University of Chicago. So she is a pediatrician and she has a PhD in philosophy. So she's an ethicist. And she and I have wrestled a lot over this because she keeps saying, but I think at some point race can be useful, right? And social defined race can be used. I mean, there's something that where we want to take this into account. We can't just ignore it. So we look at this in a lot of different ways. So there was a paper that came out in the Annals of Internal Medicine recently looking at race, BMI, and age, and when you should start screening for diabetes. And what the authors showed was that if you, through a variety, it was a very, it was a good analysis that with, if you wanted to have similar parameters, that you would start screening European Americans with a BMI of 25 at age 35. African Americans, I think and I don't know the exact numbers, I'm just going to toss them out there, like a BMI of 18 at an age of 35, and Asian Americans at a BMI of 22 at an age of 35, right? And so she said, now this is important because you're not going to be screening European Americans at a BMI of 18, right? You're going to be excessively screening. And although it's easy to say, well, it doesn't cost much to do a diabetes test, you're going to have it, we're laboratory professionals. We know false positives, false negatives, stress, all that sort of thing. So it doesn't make sense if it's vanishingly rare in that socially defined race. So we argued about it, and it's important because you don't want to say, well, we're going to screen at a higher cutoff. Now, we have to keep in mind as well, BMI was established using European American men. That's how a healthy BMI was designed. Okay, so we already have an inherent flaw in this issue. So Dr. Ross sent this to me, and I'm saying, okay, maybe this is important. So she brings it up with some other colleagues at the University of Chicago, including a very senior diabetes researcher in the Howard Hughes, who says, I'm very concerned about this. I can see, looking at diabetes based on hemoglobin A1C, based on serum glucose. He says, but associating it with race to me smacks of eugenics and has taken us back to a Nazi era. And an endocrinologist there recommended the book, which I'm currently reading, called Diabetes, A History of Race and Disease. I don't know if you're aware of this, but in the early 1900s, diabetes was considered a Jewish disease. In fact, it was referred to as Judenkrankheit. Then it was shifted, it became the African American disease. Then it became the American Indian disease. And we see through this that using socially defined race is very, very problematic. So I'm still working on that.
I am trying to get Idioma Opara unmuted, so it looks like they would like to speak, but I'm not sure. I don't have the ability to unmute. So you're welcome to put that in any comments or questions in the chat, and I'll try to get to it there because I don't believe I'm able to unmute you. We do have a number.
You can't mute Dr. Opara. She has got such a powerful voice. I can't believe she's been muted.
If we're able to do it, I'm happy to have them speak next. In the meantime, we do. In the Q&A, let's see. Dr. Parra says, great presentation and in full agreement. Additionally, there's danger in race neutrality in existing white supremacist system. Devin may be working on unmuting you. Your hand up. I just don't have the
I think I
ability
just
to-
unmuted. Dr.
Hello.
O'Hara?
You hear me?
Yes.
Yes.
Thank you so much. I want to thank Dr. Derup for her outstanding work. Dr. Graves, always an honor to listen to your work and your presentation. Just expertly done, eloquently and articulated, and always powerful. So thank you, thank you, thank you, and thank you for the kind words and for the shout out with the picture there. That was unexpected. So my name is Dr. Opara for anyone listening. And I want to lift up this work. I also want to provide some context in regards to this question that you're grappling with as posed, and I think it's a great one. There's a paper in the Lancet that was published, I want to say last year or 2020, and it talked about from race-based to race-conscious. And so what I want to lift up is, I'm sure many people are familiar with this. If not, feel free to tweet at me or DM me at INNODIM, and I can share the copy to the link to the paper with you. But I think that there is indeed a place for socially defined race. As everything you said is 100% on point, fully agreed. One of the dangers, though, is that we forget that we still live in a society built on and codified in anti-Blackness and white supremacy and white supremacism and whiteness. And we're still operating in medicine, healthcare, and public health that's still built inside of these ideologies and ways of being existing, these epistemologies that are again built on, again, anti-Blackness and white supremacism. And so when we start leaning towards, I think that there's a temptation, of course, I do these talks too and have these conversations, sometimes the reactions, well, then do we do away with race entirely? Well, first of all, to your point, well, yeah, do away with something that doesn't exist, which is human biological race. But there is a place for socially defined race because there's still a place for racism in the ways that it impacts the outcomes along socially defined racial lines. And so we have to have a way to ensure that race blindedness or color blindedness, which is whiteness and anti-Black racism by another name, doesn't sort of take the place of, well, see, human biological race doesn't exist, and so we're done. We don't have to mention that this patient is Black or white or indigenous or what have you, and moving on. There is that. Absolutely. There is also recognizing that full human in front of you who is of African descent, who identifies as African American or African born or whatever their identity is, culturally, socially, ethnically, etc., racially, which for many of us is also, again, a very key part, political part of our identity, informs the choices that we make, the families that we live in, the cultures that we express and enjoy, that speak to our health realities. It also informs the ways that society places a value on our lives and our communities that expose us to higher risks, again, along those socially defined racial lines that produces the disparities that are observed. So I think understanding the role of biological race as, not a thing, right? But also placing and positioning socially defined race in the context of racism, which created race, as Dr. Graves outlines, is important, I would posit, within the healthcare frame, within the public health frame, within the science frame, because it is absolutely a key driver, if not the key driver, when it comes to racial disparities and the outcomes that we observe, and figuring out the ways that we contextualize and have those conversations in our clinical experiences and interactions is part of the work that we are doing and that is ongoing. So I want to land my plane here. But again, thank you for an excellent, outstanding conversation.
Thank you. Your voice is always a powerful one.
And I also want to make it really clear, Dr. Oparo, that I think I completely agree with you. And I've been spending a great deal of time and ink making that point over the last decade. So we use socially defined race when we're dealing with sociological problems, but not genetic ones. And that's the problem. People conflate sociological problems with genetic problems.
Absolutely.
Although society can indeed have influences on the way genes are expressed. And that's the point that I've been trying to get across for some time. And in fact, I'm giving that very talk that you just gave to an international audience on July 7th in Portugal.
Oh, that's amazing. I hope that we get more information about that. But sir, what I found in these conversations is that you got to be explicit, because where people folks are still grappling and struggling, and that conflation is so ingrained that the easiest, how would I say, the quickest, shortest, least path of least resistance is intellectually or cognitively is adopted, which is, well, just do away with the whole shebang, right? And forget that there is a place for social defined race, because there is still racism. So thank you again for that piece there. And I hope I can follow your future talks in Portugal or wherever it is. Hopefully it's virtual.
Thank you guys for engaging and having these really, upfront conversations, because I think that, the goal of a talk like this really is to hear us talk about these things out loud and explicitly, like you said, not to sugarcoat it. So I do want to stop here and thank Dr. Darup and Dr. Graves again, and thank everybody who attended the ASCP Virtual Path Grand Rounds. It will be recorded. It'll take maybe a week, 2 weeks to get it up, but it will be on the YouTube for the ASCP VPGR, and I've put that link in the chat. Also, a reminder for any residents or trainees who want to join, there will be a roundtable following this. It has a separate registration link. It will not be recorded. It is meant to be an open discussion with Drs. Darup and Graves about these topics in more depth. So again, thank you on behalf of ASCP for attending and engaging, and I hope that we can all take something about these topics and move them on into our lives as pathologists and medical professionals, because this is really important work, and we're very fortunate to have leaders like this talking with us. So with that, we'll break. We will stop this presentation, and if you're a trainee and you're joining the separate presentation, that will be a different link. So thank you again, and everybody have a wonderful rest of your day.